Thanks everybody for coming back. I hope everybody had a great night last night. And I know you were feeling anxious, you wanted to hear data. And what better way to digest your food than to come in first thing in the morning and have a bunch of data thrown at you. So this really is interesting stuff. And I hope you appreciate the fact that data has to be what drives decisions. Probably right now at home, you guys are facing a decision because how many people are seeing down volume since January 1? And this is the period of time where your administrators are going, what's going on? Are you gonna chase everybody away? And are the impacts of ACA happening now? And everybody's waiting for that ball to drop. What's the reality of why our volume is down in the emergency departments since December? The flu's not here. And yesterday the CDC published its what flu is out there is a great match for the flu vaccine this year, and we have a lot of B virus, which produces a milder clinical course, doesn't affect the vulnerable populations. Children's, we've had some outbreaks of RSV across the country, but nothing too severe, and so we have these natural variations. And you've got to remind your administration as soon as spring weather gets here, we'll be back on our average daily volume run. And just like every other year, we should expect that we'll see a 2.5 to 3% increase in volume for this year. And so I know all of you have to take something home related to that. And the message is volumes are down because the viral load in the country is down. We had a good match this year of the vaccine. Every 10 years or so, the CDC's guess on what the flu vaccine needs to contain. Last year was a poor match, and we had a severe outbreak, and we had a lot of people sick last year. If you remember, February last year, we were in the peak of this, and I told you that one ED in Lakeland, Florida, their average volume is between 500 and 550 a day through one set of doors, and last March, they set their volume record at 764 for the day coming through those doors. So we're going to talk about data and performance measures. 3 facts you need to go home with from this presentation. How many visits to the emergency departments in the United States last year, 2015? Okay, ding, 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 make your guess. What percent of people who arrive in an inpatient bed, whether that's admit or obs, what percent of them get processed through the emergency department? And the RAND data released in 2013 said it was 52%. That number is wrong, okay? That number is wrong, and I'll explain later. You can figure out which of the 3 numbers there is correct. And then finally, what's the most important driver of ED throughput? And what drives your walkaway rate? Door to bed, door to doctor, boarding time, or visits per bed, essentially how crowded your emergency department is, all right? So 3 things. So we're going to talk about what we're facing now, and most of you at home, and probably one of the reasons that you're here, you're considering walkaway rates, and somebody at your hospital is upset about those; they're too high. You're trying to address boarding time, and then we have clinical measures that are coming, and Sherry and Nick already mentioned some of those, but our clinical measures, both for the practitioners and for the department overall, have been coming to us. So. You went through the history already. Every 4 years we have a definition summit. That's because when Bruce put this together in 1994, we had no consistent definitions of anything. And so we needed definitions, so we meandered along for about the first 10 years and then decided that we needed to have a summit. We needed to put people in the same room and organize the definitions that will drive this industry. Sherry and Charlie Reese were the lead on this. Sherry published, and in 2006 we sat in a room in fire headquarters at Atlanta Airport. We had done some pre-work on the internet, which was a really new tool to use at the time, and then representatives of ACEP, ENA, EDPMA, American Hospital Association, Joint Commission, CMS, sat in a room and we said, what is a patient? What is a length of stay? Are we going to use means or medians for length of stay? And in one day, we hashed out the definitions. So that was published in 2006 by Sherry. We reorganized this and did the same type of summit in 2010, focused on intake systems. And Sherry brought in 10 people who did a presentation on new intake systems for the emergency department, who was using team triage, who was using APPs in the front, et cetera. So 10 different models of that, published those results. And then, as you saw 2 years ago down the hall, we did our third performance measure summit and published those results. The next challenge that the federal government has presented to us is it said that we need to know if there's any quality amongst the specialists in this country. And in CMS speak, they said, we're not going to pay for low quality. Are you all impressed? Yeah, that's really important message. What that really means in federal speak is we just are finding an excuse not to pay you. So you have to address these issues. So each of the specialties has been asked to develop a way to measure competence and high quality in the specialty area. Emergency medicine has been handed that responsibility. I sit on the board of directors of the American College of Emergency Physicians, and on behalf of 34,000 members of the college, we have to be able to address this CMS issue of quality measures for emergency medicine practice. And we put together a qualified clinical data registry and gave it a name. That name is the Clinical Emergency Department Data Registry, or CEDAR. The model for CEDAR, just so you all know, is something that has been humming along for 40, 50 years now, called the Trauma Registry. And even longer than that is the Tumor Registry. And the Trauma Registry, for mostly trauma centers on a computer system that was developed many years ago, when trauma occurs and you're part of a trauma system or you're a verified trauma center, in the background, behind where you're taking care of the trauma patient, they're collecting data. And the Trauma Registry has hummed along for 40 years, developing clinical pictures of motor vehicle accidents, pedestrian struck, motorcycle wrecks, et cetera. They have been measuring hospitals versus other hospitals. They've been measuring surgeons versus other surgeons, et cetera. And if you will, it's a background program that you as clinicians don't even realize is going on. So with that model, we would like to look at the emergency medicine practice and develop measures of competence. We would like to look at the overall population of emergency department visits and be able to take from them good emergency medicine practice, be able to note trends, and then be able to give the federal government what it wants in terms of performance measures for individual physicians and individual APPs in emergency medicine. So that's what CEDAR is about. It has its own website. It's really getting on its feet right now. This is our first year, and anybody who participates will get the CMS reward for participating in a qualified clinical data registry. And so for the emergency physicians and emergency APPs in here, this is the tool being developed for you. All right, so back to what we are doing in the emergency department. How do we get data? How do we know what we're doing? How do we know what we're supposed to design for? So going back to 1994, when we founded the Benchmarking Alliance, there was really one evolving data source, which was the CDC's National Hospital Ambulatory Medical Care Survey, NAHAMSIS. They were beginning to look at what was going on in emergency departments and using a sampling technology, figuring out what was seen in EDs across the country. One of our early functions was to assist them in the development of the NAHAMSIS Emergency Department Survey. They were going to look at individual visits. We looked at emergency departments. Get the difference? We don't look at any individual patient data. We look at how the emergency department performs as an entity. And the CDC was humming along. Linda McCaig was the lead researcher in the CDC office. And as I said yesterday, she retired last year. And there's currently a void in the leadership of that study. We have our own survey, and then CMS, who participated with us in the definitions. And I want to tell you, it was not a passive process. We were leading the discussion. Sherry, Charlie, Nick, and others were leading the discussion about what would be good measures in our industry. and what would be good performance measures for the federal government, because there was a former leader in emergency medicine who insisted that the Hospital Compare website had to have a time measure on it. Every specialty is getting a feature on the Hospital Compare website, and they wanted a time measure. And so his initial idea that he expounded on at length was he wanted average length of stay in the emergency department as a marker of quality. And he wanted to advertise that and then tell his Medicare beneficiaries which emergency department to go to for their emergency. How many of you run under 20,000 visit emergency departments? Put your hands up. How many of you would like that as a measure for emergency department performance? You'd say, what? Piece of cake. I can't do anything wrong in a 20,000 visit ED and drive up average length of stay. How many of you run over 100,000 visit EDs? Real easy for you to drive average length of stay down, right? And if we use average, what does that mean? All those long outliers would get included. With that background, we went and sat and met as the benchmarking alliance, said, what should we be doing about this? We got to have a time measure. And the federal government really says that they're going to put something like this on a big website and ask my dad to go and take a look at that website and make a decision about where to go to get his emergency care. There's still some disconnects here. But what does every hospital have a chance of getting low, no matter what their volume is? And what would be a good measure to give each of you as ED leaders traction when you have to go up to the C-suite and make your asks for what you want and what you need to run your department? So contemplating that, we said, if we use boarding time, you 20,000 ED visit managers would say, I could do some work getting my boarding time down, because a lot of times, they're not staffed in my small hospital and they leave patients in the emergency department. It's still tough for us because we're not staffed to take care of a whole lot of people. And then you 100,000 visit places, well, we have room that we could improve our boarding time. And boy, if we could get those 30 people out of our emergency departments on busy mornings, that would really help. So we suggested to CMS that they use median boarding time as the measure that they post on the Hospital Compare website. And we asked them to do that, thinking that that would give all of you traction to be able to make decisions and help your hospital improve flow of inpatients going upstairs. Fair enough? And if we had to put a time measure there, did we do a pretty good job of thinking through what would be fair to all emergency departments? Since, by the way, one other discussion with Medicare is you got to break out the different types of hospitals and emergency departments. They still haven't heard that discussion very well, although every year they get the results of our surveys and understand. And then the other thing about their beneficiaries is, can you imagine me telling an older person who lives in Philadelphia and give them the Hospital Compare website data, and then say, your best waiting times or your best performance of an emergency department, your lowest boarding time is 60 miles to the west in a small little emergency department. And so you as a Medicare beneficiary listening to your federal government say, well, I'm going to drive out there with my exacerbation of congestive heart failure because they have low boarding times out there. And then you see in the emergency department there, it says, gee, you really need to go into the hospital and you really need to be admitted at a place where they can serve your full needs in the heart service. So we're going to transfer you back 60 miles into Philadelphia. So there's still some logic missing here, but your federal government is looking for answers. And we are doing our best to not have them come up with answers independent of your needs and what will serve you well. That is our responsibility as an industry, is not to wait passively for people to give us measures. We instead need to be ahead of that, developing definitions, performance measures, handing them off to the regulatory agencies and saying, if you're going to use something that's reliable, qualified, effective, and by the way, gives our ED leaders traction to get stuff done. So understand we have gone from being a passive organization to a very active organization, and things like definition summits and working with the federal agencies gives us more opportunity to be ahead of this rather than waiting for things to happen to us. A couple things. Recently, state and local governments have come up with some measures and occasionally report that. I get news clippings from across the country, and occasionally they will have things like the performance measures across a metro area published in the local newspaper. That affects you guys, and you got to be aware when that stuff is coming out, and you got to have accurate data in it. And then AHRQ is beginning to get more active, and one of their studies is an expenditure care survey, which is going to bite us if we're not really, really careful. So let's go through. So I told you yesterday that NAHAMSIS hasn't published any new data tables since 11, but from 92 to 11, 20 years, the average growth rate of emergency department volumes has been 2.5% to 3%. Acuity is higher. We're seeing sicker patients, and the effects of minute clinics, urgent care centers, doctors keeping their offices open has resulted in acuity going up in the emergency departments. And acuity up means more elder patients with more medical problems. There's your visit rate up, and there's answer to question number 1 up in the right-hand corner. So the last official tally from the CDC is 136 million visits in emergency departments in the United States in 2011. If you do a simple 2% growth rate, which I do not believe really reflects, I think our growth rate in the EDs since 2011 has been higher than 2%. But the correct number for ED visits in this country is at least 150 million emergency department visits. All right? And then what the CDC does that nobody else can do is pull this into population data. So when you look through the data tables, you get utilization by age and gender and ethnicity and by insurance class, and then what we're presenting complaints, what was done to the patient and what was their disposition. So on one slide, and this is a very important slide and one that you should use in your presentation to local boards and your community resources. This is the slide that says, where do our patients come from, how often are emergency services used in our community, and what happens to people after they've been in the ED. So the number, and I can't give you anything newer than 2011, I'm sorry. There's no data source other than the NAHAMSIS study that tells us about utilization. And 2011 utilization of EDs was 445 visits to the ED per 1,000 population per year. 445 per 1,000. That means by statistics, every 2.5 years, everybody in your community visits an emergency department as a patient. Got it? That's a big number. What do you think it does in comparison to Canada? 445 per 1,000. Compare, anybody here from Canada? They're in the back. What's your number in Canada? Almost the same. Almost the same. And so 445 per 1,000. A certain percentage come by EMS, a certain percentage walk in. And then you'll see the big breakdown is we watch 2% of them walk away. So our walk-away rate across the country in all EDs, 2%. 2% get transferred to another hospital. 17% are admitted. And about 81% are treat and release. And this is your responsibility. In most EDs in this country, 70 to 80% of the people that we see, we treat and release. So the majority of the people that we deal with are going to be sent back out the door by us. But it's really what happens to that 17 to 25, in some cases higher percent, admitted patients that drag our operations to their knees. Okay, so that's a very important segment as well. All right, so 14 into 15. So our ED database is a little bit bigger than Nick presented. So 1,126 EDs plus about 75 freestandings and urgent cares. So we had about 1,200 departments that have sent us data, 14 moving into 15. That represented 43 million visits. The volume from 13 to 14 was up about 5% in our benchmarking alliance members. And I think it's going to be equal 14 into 15. All right, so we had big volume jumps, I believe. And again, match this to what's going on in your community with minute clinics and urgent care centers, et cetera, and still people are coming into the emergency department. Admission rates are stable. Flow is improving, but boarding is the big driver of flow problems. And then our use of diagnostic testing is evolving. And we have really good markers on this. ultrasounds and MRI scans and EKGs are our biggest use of diagnostic tools, and we have plateaued and begun to decrease a little bit on the use of CT scans. So in our discussion late yesterday afternoon, we saw that CT scanning is an issue for some of you, and you get called to address it. Volumes are changing the design of the emergency department, more CDUs and fast tracks. A very important number, and one which I get interviewed for the media all the time: what should the door-to-doctor time be in our community? We understand there's a place that has a 90-minute door-to-doctor time. How does that compare to national statistics? 2011, the CDC measured it at 27 minutes, and within the Benchmarking Alliance data set, we are under 30 minutes as well. Door to provider, which in most places means door to physician. In some places that means door to APP. Just so you know, our definition would include both. And mental health burden, and the CDC at our request has been watching the mental health burden grow in emergency departments, and all of you know what the impact of that has been. How are EDs performing? Well, as a group, under 40s cruising along. Under 40 grands, you're cruising along. 40 to 60 are where it begins to be a management challenge. 60 to 100 are where people are doing CPR on the ED leaders. Okay? You guys who run 60 to 100,000 volume shops are the ones who have the most stressful jobs and the most difficult time maintaining flow. And then Charlie Reese, who is from Christiana Care and was our president for the Benchmarking Alliance, said, we built this ED out in the cornfields. It was supposed to see 35,000, and of course, after 2 years, they're seeing 50 grand. And then they marched just right straight up and got over 100,000 within 10 years of it opening. All right, so a place in the cornfields to 100,000 plus. And it seems, statistically, when you watch EDs do that the C-suite, they watch you go up in your volume, and you get to 40,000, they're like, really good job. And then you're at 60,000, they're like, you guys busy, but it's going to stop because, managed care is coming or whatever it is. And then you're just crucified 60 to 100, and you're struggling to get stuff done and reduce boarding and get staffing stable and get enough specialty coverage. And then it appears statistically that the day that it hits 100,000 volume, the CEO walks into the emergency department and says, I guess you've passed your stress test. What is it that you need to make your emergency department work more effectively? And so somewhere at CEO school, I told you one fact in CEO school yesterday was 2,000 visits per bed. The second fact is if you get to 100,000, they got to come down and meet you and say, what is it that we can do to make your ED operation better? And so the statistics would say 60 to 100,000 are the people who should be sitting in these seats looking for best practices to make their EDs better. And for those of you going 40 to 60, you know where the trajectory is going to take you, so you should be here as well. All right, so in your handbook is the data sheets. Just so you know, we've broken up these cohorts since the first day we did the Benchmarking Alliance. The funny story with Bruce and the others is we were in 94 getting to 100 visit a day emergency departments, 40,000 a year, and it was a crisis. It was very difficult running those places. And we recognized that EDs at about the 20,000 volume marks change their operations significantly. Those are the times, for all of you, you should expect stuff to really get disruptive, is at the 20,000 volume marks. We've been told that we should break this up by quartiles and quintiles and all that kind of stuff, and it's like, no, this 20,000 volume mark for whatever it is, 55 patients a day. Under 55, you have a place that cruises along, one physician, some nurses, no clerks, maybe a tech. At 20,000, you're like, oh, we got to put an APP in, and we got to begin to do some triage, and then finding patients is tough. And then you run the same way up to 40 grand, and then things change again. Get the picture. So 20,000 seems to be our key time of changeover of operations in departments. We also, as we have gone through the years, had to keep adding 20,000 strata at the top. I told you yesterday in the 14 data, there's 55 EDs over 100 grand. 55 of them that max out with Lakeland and with St. Joe's in New Jersey at 162. So that's EDs with one set of doors. Anybody who gives us compiled data for 5 different sites that all get included under one tax ID number, we break all of them apart because those are 5 separate emergency departments. Get it? And then as we've gone through the years, we keep adding those strata. So this year we'll probably have 120,000 plus strata, all right, cohort. And then we've also had enough EDs that see adults, see children, and our freestanding or urgent care is associated with our members. So we don't have Joe's Urgent Care Center in the database. This would be St. Elsewhere's Urgent Care Center associated with the emergency department there. They wanted to put their data in, so that's the last strata on the bottom, all right? So coming through and cutting through a little bit of the data, what are things that are interesting? Well, here's one marker, so you get used to seeing these graphs because many of our operative pieces look just like this. Where you have, this is our left before treatment complete, a reflection of all of the people in our group who said, you know, we cheat on this statistic. We call them elopes in RED and then they don't count. Or we call them AMAs in RED and they don't count. Or we call them left before triage, left after triage but before treatment, etc. Every one of you has an urge to cheat on this statistic. So left before treatment complete says no cheating, all right? And we can't get good comparative data if everybody cheats. So left before treatment complete means everybody who left before they're supposed to at any time. And no matter what you brand them in your department, all of them get added. And as you see here, big EDs have a hard time keeping people in the doors once they've gotten there. You see adult EDs have a hard time, but small EDs and EDs that serve children, it's relatively easy to keep people there. And if you will, this is our marker of patient happiness with the services, all right? Length of stay. So all these curves look very similar. I just want to make you aware how our 20,000 volume cohorts have worked over the years and how they still seem to be the right use of our data to cohort emergency departments. This is very important in the data. So the decision time, which Nick and Bruce alluded to earlier, is a difficult definition to make. In emergency departments, let's just say the average admitted patient waits 5 hours, 300 minutes. What percentage of that time is before decision and what percentage of that time is after decision? And after decision is what we consider boarding time, okay? And right now we're running at about 40% boarding times. So admitted patients, about 60% of their 300 minutes is waiting for the emergency physician to decide and push the button that the patient needs to be admitted. And about 40% of the time is the time that occurs until the patient physically leaves the emergency department to go to an inpatient unit. And it's really fairly stable across all the cohorts, right? There's not a great deal of variation in that number. I got to go backwards and say the boarding time, the actual numbers are in this third column there, the middle column. And for all EDs, we're just under 200 minutes. I'm just under 2 hours, 112 minutes. And unfortunately, we have not been moving this number very much over the last 3 years that this has been collected. And so our effort to give you traction, sand to throw under your tires when you go to the C-suite, we have not been successful enough, and our urge is for you to use this data to go back to get the traction that you need to get flow in the hospital under control so that admitted patients get upstairs for better care and lower overall length of stay and better quality outcomes if they leave the ED earlier in their stay. We use box and whisker diagrams to describe a lot of our data, and that is because many of you asked that we demonstrate our data in a way that we show average of the means, okay? And then you can take a red crayon and put your cohort here and where you are in the performance measure. You can take a crayon and mark on a piece of paper and hand that to your CEO, CNO, CFO, whoever it is. So this is the kind of data that allows them to know you're looking at your data, you're looking at the statistics of it, you're looking at standard deviations, you understand that, you understand box and whisker diagrams, and here's the number that we're focused on. Our boarding time in our department is too long. It's more than our peers. We're 3 standard deviations to the high side. We got to do something about that. What can we do to assist the hospital in addressing this so that we can address the needs in our ED, we can address the ED patients that need our care, we can reduce our walkaway rates, we can reduce our processing time for all patients seen. So that is why we have given box and whiskers, but you can use the data any way that you want to demonstrate the outcomes that you need. All right, question 2, what is the use of the emergency department to get patients upstairs? If you will, there are 4 doors to an inpatient bed. 4 doors to an inpatient bed. You can be transferred in. You can be direct admitted. You can come through labor and delivery, or you can come in through the ED. Generally, there's 3 big contributors to this. For those of you who work in centers where they transfer in a lot of patients into your ORs, into your cath labs, into your ICUs, you may have a significant transfer in. Some of our academic centers, and the ones that RAND surveyed to get to their 52% number, were big academic centers. That's why they reported a 52% number. It is not representative of the 5,000 emergency departments in the country. So that is how RAND came to a 52% number. When you look at our database, 1,200 hospitals, we didn't count the freestandings and urgent cares because they don't contribute to this, right? So they're excluded. So 1,125 hospitals. If you don't have a labor and delivery unit, your contribution to the upstairs is about 80% of butts in beds came through the ED if you don't have labor and delivery. Some as high as 90%, all right? If you have an active labor and delivery unit, then you come down, and on average, 68% of admissions in hospitals across this country are processed through the ED, 68%. So 2/3 of butts in beds upstairs come in through the emergency department. We'll talk about the dollars associated with that in a minute. So we include both OBS and admit, just so you know that what the data includes. The ED, emergency physicians and emergency nurses in here, do you care whether the patient's going to OBS or admit? Do you have anything to do with that decision? It doesn't matter. I've got a sick person here. They're going upstairs. I don't know. In many cases, I don't know whether they're a full admit or an OBS admit. And that's beyond the scope of our practice, and is beyond the scope of interest of the emergency department. They're going upstairs somewhere. And so there's our numbers. And remember, keep these different. So it's on average 17% of patients who arrive in the emergency department are going upstairs. So that's about the average number. Some as low as 5%, some as high as 35%. Okay, so that's about our range in patients arriving in the ED going upstairs. But upstairs, 68% of patients upstairs arrive through the emergency department on average. All right, I talked about testing, ultrasound testing going up, MRI scans going up, EKGs going up, CTs stable, plain imaging actually going down at this point. All right, very important. Bruce remembers. We face this decision. The CDC measures the percent of patients who get a CT scan. The percent of patients who get a CT scan. Their number in the early days was 8, 9, 10%, because their data overrepresented small emergency departments, and their data represented the percent of patients who got a CT scan. So when Bruce and I had this discussion with the CEOs, the CEO came with the head of radiology who said, "You guys are using too many damn CT scans." And they would plop a piece of paper in front of us and say, "Your number is 20. 20. The CDC says 8. And so you guys are overusing the CT scans. What are you going to do about this, Dr. Janiak?" And he says, "Well, let me take a look at the data." And so he asked the head of radiology, who can I pick on? The head of radiology, "Where did you get your data?" "Well, this is our data on CT scans originating in the emergency department." "Sir, what does this include?" "Well, this is all of the procedures that we build for in the emergency department. You know, Bruce, you saw 40,000 patients, and you did, what was it, 8,000 CT scan procedures." And I know how many patients you saw, so I divide 8 by 40,000, everybody with me? 8 by 40,000 equals 20%. And the comparative number is 8. And Bruce says, well, those aren't the same numbers, sir. Your procedures include a scan with and without contrast. And what is every kidney stone scan? Every kidney stone you send over to the suite has at least 2 procedures billed for. CT of the abdomen, CT of the pelvis. Every trauma patient in his trauma center shop has 8 or more billed procedures. So, sir, let's go back and look at this. Now, Bruce doesn't count what percent of patients get a CT. All he knows is the number of procedures that are done, and all he knew was the number of procedures that he billed for from his radiology department. That number is much higher than the percent of patients, and neither one of them count unless they would go through in Bruce's shop and do a hand count and say, I'll look at my 150 patients seen today and see what percent of patients got a CT, but many of the patients who went over to your procedure lab had multiple procedures done and billed for. All right? So it turns out when we collect our data, the trauma center that has comparable data from other trauma centers that are 40,000 plus. The correct number at the time was 28. It was 28. So, sir, let's meet with the CEO and discuss this, because actually we're under our industry standard, which was for a trauma center over 40,000 volume. It was to do 28 imaging procedures per 100 patients seen. And he's pointed out very astutely that we're only doing 20. So I'm going to go ask my guys if we can do more scans so that we can get up to the industry mean. Get it? You really got to be careful. There was one other statistic brought to us in our early days, and Bruce and Dan Shelby took this also to the blues, because the CDC said 12% of patients are admitted to the hospital from the emergency department. 12%. One standard deviation is 15%. And what kind of EDs did I tell you the CDC was measuring a lot of? Small, low volume, low acuity emergency departments. Their statistic was 12% on average of ED patients admitted to the hospital, and one standard deviation was 15. Bruce comes to us and says Anthem wants to punish any hospital that admits over 15% of patients, saying they're a low-quality ED with lazy emergency physicians who don't know how to make triage decisions and therefore admit everybody because they're lazy. Get it? And so we looked at the CDC data and said, this is not about high acuity, high volume emergency departments. As a matter of fact, at Bruce's shop and at our shop and at other shops in the Alliance, we couldn't get under 20% admission rates unless we recruited healthy volunteers off the street in to be registered in as ED patients. So Mr. Anthem executive, this measures very astutely low acuity, low volume emergency departments, but I'm sorry, in any of our high volume, high acuity shops, you can't get to that low an admission rate. And so it's very important that you have this data, be able to recognize it, and in a couple of places, the CDC is different than ours. There's the demonstration MRI and ultrasound, and I want to talk about the value of emergency care and our financial issues, because right now we are butchering, as an industry, we are butchering these discussions. We don't use the words cost, charges, and reimbursement in any way that resembles any kind of reality in our industry. Surprise bills is the new industry language here, and frankly, we have got to, as the people in this room, we got to get a handle on this, because our charge masters have gone through the roof, and our bills for emergency services, you're going to see in a minute, look stunningly high. And the insurance industry has portrayed these as surprise bills. And you're going to see over the next few days, ACEP is going to come back and say, this is not surprise bills, this is surprise coverage. That people who buy insurance products who think they have insurance and don't have insurance, this is not about the bill being a surprise. This is about the insurance non-coverage being a surprise. Better get the difference? And so here we are with the problem. So I told you AHRQ got involved. So MEPs, Medicare Expenditure Panel Survey, asked consumers, how many bills did you get for your visit to the hospital? And what were the total charges? And then what was paid on your behalf, either in cash or by the insurance company for your visits? They selected out emergency department visits, and in their early data from 2005 to 2010, this number alone may surprise you. Average bills that the consumer received from the ED, from X-ray, from the emergency physician, from cardiology, radiology, totaled over $2,000 for an ED visit. Over $2,000 for an ED visit. And what was paid was, for Medicaid, about $500. If you were Medicare, $1,000 on those charges. Get it? Charges, reimbursement. Charges an amount of money going into the hospital and the emergency physician's pockets. This data, unfortunately, at the federal government level hasn't been updated since 2010. But individual states are doing some of this same kind of surveying. So my home state in Florida, their floridahealthfinders.gov, they are continuing this survey. And in Florida, over 8 million visits to Florida emergency departments. For any of you from Florida, there's a nice listing of every hospital emergency department in the state, how many ED visits they had, average charges. They don't have collections or reimbursement. It's just about charges, all right? So over 8 million visits. In their text, they say half of them are avoidable with no definition of what avoidable is. And they found in Florida, for the 2014 year, $4,500 average charges, more than double since 2010, all right? And if we nationalize that to 150 million visits at $4,500 per visit, we're going to talk about a trillion number. We are $682 billion in charges for patients visiting the emergency department. That's 2/3 of $1 trillion. There's real money coming through the ED. All right, so I'm going to finish this. What's the fiscal impact of a functional and dysfunctional ED? Let's say you're an average $50,000 emergency department. That's 137 patients a day, 25 by ambulance, and an 18% admission rate. That's 25 admissions a day. Usually the EMS arrivals and admissions are about equal. The CFOs would say a contribution margin for an ED admitted patient is about $6,000. All right? And if we use our standard times, those are our standard processing times. At 137 patients a day, at I just gave you a hospital charge of $3,000. I'm $1,500 under what the Florida published number is. Let's say it's $3,000. So your charges for the hospital's emergency department are about $411,000 per day. If we say that there was a collection of $1,000 by the hospital for each ED patient, that's $137 per day, plus the $150 contribution margin for the 25 admitted patients. You with me? Big numbers. Because that $287,000 a day adds up to over $100 million a year in revenue, real dollars coming in for emergency department patients. The emergency physicians, if we give you an average charge of $250, average collection $125, those are $35,000 and $17,000 per day. This dysfunctional ED, and this is the numbers that Sherry uses some, what's the fiscal impact of this? And if we tell you that they're on diversion and watching a 4% walkaway rate, and oh, by the way, typically watching staff walk away and get dissatisfied, the tab is at least $10 million. At least $10 million. And if you divert, it's much higher because you're missing admissions when you go on diversion. And added expenses related to satisfaction and the management. So if you spend, I gave you a little thing here to use, well, let's clean up our dysfunctional $50,000 emergency department. Let's hire some techs, let's hire some nurses, let's add an APP shift, let's put everybody through charm school and spend a couple $100,000 putting them all through charm school. Let's say no diversion and figure out what doing away with boarding would do to eliminate diversion and see what kind of a fiscal impact. The ROI on this is incredible. But if you spend $3.2 million to save $10.2 million, the ROI is immediate and priceless in terms of staff satisfaction. So things are changing. We have to be able to stay ahead of all of this. And I'm urging you again, this is not about passive behavior. This is about active behavior on your part. We have stuff coming ahead, and you have to be able to manage it, and you have to have the data to be able to manage it. We have some data sources. Unfortunately, they're getting sparse because of decisions the federal government is making. But the Benchmarking Alliance and other local groups that you belong to and can contribute to can make a difference. The difference we need to make is on behalf of the patients that we take care of and the staffs that we're all responsible for. And we got to give them the pictures of what is coming ahead. That's what our data is about. So I will stop, and thank you for the opportunity to speak on data. Thanks, Sherry, for giving me the opportunity to do that. I'll take questions later.